Okay, we're now into the hundreds, so I suggest we start. Welcome everybody. My name's Susan Mickey. I'm Professor of Health Psychology and Director of the Centre for Behaviour Change at University College London. Welcome to the session on behavioural data in action, the role of self-reported and other data. The objectives of this session is to understand the nature of the data generated directly from patients and public, to illustrate some of the challenges and methodological issues of collecting and using behavioural data, and to highlight the current and or future role of behavioural data in decision-making and the impacts the data can have on public, patients, policy and research. We're going to have 3 6-minute talks with a couple of minutes after each for any direct questions, and then 15 minutes, assuming everybody sticks to time at the end for general discussion. And Melissa, who is with us in the background here, is going to handle the questions. So please, during it, do put your questions into the chat function. The 3 speakers are going to cover roughly in their order. First of all, using behavioural data in a descriptive sense, so directly measured behaviour. Secondly, using it in a more predictive way, so modelling based on a variety of data sources. And finally, as explanatory data as an explanatory process to understand both behaviour and behaviour change. The speakers I will introduce, they are in a different order than in the programme, and they also have rather different titles in the programme. So bear with us. Delighted to welcome or introduce the first speaker, Ed Manley, Professor Ed Manley, who's going to talk about new forms of behavioural data for understanding the pandemic, strengths and limitations. Ed is Professor of Urban Analytics at University of Leeds and also Turing Fellow at the Alan Turing Institute. And during COVID, he's been using a variety of movement data sets to understand changing patterns of behaviour, including in hospitals and between houses. Ed will be followed by John Edmonds, who's Professor of Infectious Disease Epidemiology at London School of Hygiene and Tropical Medicine. He led the Polymod study, the first large population-based study designed to quantify epidemiologically relevant contact patterns for use in mathematical models. And the title of his talk is The Impact of Social Distance Measures on Epidemiologically Relevant Contact Patterns, bracket the COMIX study. And thirdly, we have Stephen Reicher from the University of St Andrews, who's Professor of Social Psychology. He also participates in SPI-B, the behavioural science part of SAGE, and advises the Scottish Government on COVID. And the title of his talk is From Description to Explanation, the Use of Survey and Experimental Data in the COVID Pandemic. So I think we've got a great series of talks, and I'm delighted to hand over to Ed.
Okay, thanks, Susan. Let me share my slides. Okay, you should all be able to see that. Hearing no complaints. So yeah, I'm going to talk about new forms of behavioural data that can provide us some insight into when just describing changes in behaviour, and with a particular focus on a couple of applications in the pandemic. I just need to mention the projects that are involved here are the SAFER project, which is MRC funded, and the Consumer Data Research Centre, ESRC funded, and a few of the collaborators involved in this work. So I'm coming at this from a geographer's perspective. I look at, prior to the pandemic, I was looking at movement data, behavioural data, activity data from a variety of sources. And these, the ones I'm very much interested in are those which involve many samples of large numbers of people. They're generally passively collected, usually part of another activity. I'm particularly interested in those data which involve space and time. So we're starting, we're thinking about where the event is happening and when. And often these data come with anonymized identifiers at the individual scale or metadata that can be derived from the data. So things such as a home area or a job role. And when we bring all these data sets together, we can build out these aggregate picture of what's going on at a large scale, or how people are acting, at least as we observe them at different spaces and times. And that spatial and temporal data and the metadata can be used in combination with other data sets to start building out understanding into how people are behaving and acting in different locations. And the nature of the data, given its size, its routine generation, allow us to circumvent some of the biases that may be associated with other approaches. Now, there aren't not issues without these. I'll come to the end, but we can start to start to move around these. But of course, there are challenges as well. Issues relating to preservation and privacy, and so it requires careful treatment of data, non-re-identification, aggregation, but there still remain risks about how these data are used in terms of penalising populations. So I'm just going to go through a couple of examples in terms of the pandemic where we've been using these types of data. So be super quick, but any questions I could cover after. So the first is using observational data in the form of card access logs, roster data, and patient interaction data to understand how healthcare workers are exposed to COVID in UCL Hospital. So this is part of the SAFER study. And what we can derive are locations and times of where people have been, and then how those movements and their patterns of behavior have led to positivity in their COVID tests. And so we can start to establish not only the sort of characteristics of the healthcare workers that lead to higher risks, but also where they work and when they work, and really gets very specific about the locations at which people might be working that lead to higher risk from COVID. And because it's historic data, we can do this without intervention, without causing interference within the treatment of patients or interference to working patterns. And you can see some of the results. These are very preliminary results, so I don't want to go dwell on them too much, but we can start to see things like night shifts coming out as representing a higher risk for healthcare workers, and obviously the number of patients they interact with as well. But we can, as I say, with this early work, but we can start to build this out over space and time. Another example of this is using GPS traces, which have been collected over hundreds of thousands of individuals who consented to provide their GPS data to a company, in this case, Cubic. And what we have done here is start to derive patterns of behavior over space and time. And in this case, we're interested in visitation to their non-home households, so to other households. And as you'll recall, there's been varying levels of what's the right word? But legality, I suppose, in relation to those kinds of activities, and we can start to see how these patterns of behaviour varied over time. In particular, we see a big dip in the first lockdown, but an increase in the number of visits to other households during the year, and then dips to a lesser extent at different lockdowns with a relaxation towards the last part of the year. We can unpack this into spatial variation too. So we start to see that, London and the Southeast see higher levels of household visitation. And we can also start to validate this with other similar data sets, such as that, in this case, generated from Google in terms of their visits to different land uses. So that's, again, it's another use of these behavioral data. But of course, there's a but. These data sets give us breadth, descriptions, but not much depth in terms of what's going on. So we really are quite indicative rather than offering a great deal of insight. We also have still remaining issues in terms of bias, who generates the data, when the data is generated, and why. And often, while we can build in some context in terms of from over space and over time, when policies are in place and not, for example, and we still lack individual level context. We still don't really understand what are the constraints or what's acting upon the individual. And there are ambiguities around the generation and the provenance of the data. But, I think this approach should be seen as another tool in the toolbox, not a rival as it too often is. And I think, collaboration is a way forward in this. How can this data can guide smaller scale studies? There's some interesting points there there's some interesting trends occurring, from February onwards in terms of household visitation during the third lockdown, which we don't really know that much about, but it's something we could start to explore with smaller scale studies. And of course, we can also carry out validation studies with smaller subsamples of individuals to start confirming or refuting the assumptions that we might build from these large scale studies and understand the biases. And then, of course, there's simulation to modeling, which can start to explain what's actually happening and fill in the gaps of our understanding. So that gives you a bit of a flavour of those sorts of data. Thanks. You're on mute, Susan.
Thank you. Thanks very much. And I think what's particularly exciting about collecting these kind of data is that they are observational of what people are actually doing, not just what people say they're doing. And this is a really big step forward. And as technologies improve, so that way of collecting more direct data will improve. Now I can see a couple of questions, only time for one question at this point, but we'll pick up the other questions during the general discussion. So actually, for all the speakers, but for you, Ed, this time, what do you see particularly as the benefits of linking this range of data types for patients and the public, and how will these data be safeguarded?
Well, let's take the smaller scale study in this case, so of the hospital. Certainly in terms of linking those data sets together, we can start to identify areas where there are higher risk of COVID spreading between patients and staff, and put in specific policies or further studies that understand why that is occurring. So I think that's the benefit in terms of the policy, directly linking through to policy. When you get to the national scale, it's more difficult. It's many more factors occurring and actually less understanding of what's going on the ground. So I would be more comfortable in terms of these data as a primary approach in terms of working within the hospital context. But there's such a breadth of these data sets, and there's many more studies than I've presented in that 5 minutes. That it's hard to generalize, but as you say, there's a lot of potential in leading the sort of focus of the studies.
Okay, there was a question about safeguarding, but let's come back to that in the general discussion. So delighted now to move over to John Edmonds.
Thanks very much, Susan. I'll see if I can share my screen. Hope that's visible to people. I'll put it on to.
Yeah. That's good. If you can put it on full screen. Perfect.
On full screen now?
Yep.
Okay, great. So I'm going to walk you through a survey that we've been doing since the beginning of the first lockdown in March, called the COMIC survey, which is designed to try and give it input into epidemiological relevant contact patterns that we then use in mathematical models. So it was designed specifically with models in mind, but it's useful for just interpreting what's going on in the community anyway, or at least we find that it is. And this is a lot of work by a lot of people, the key people being Chris, Amy, and Kerry, as well as Kevin, who I haven't listed here, and there's a whole bunch of other people listed at the end on the last slide as well. So what is it? It's a survey of about 2,500 people every week. We actually do it in 2 panels. There's 2 panels of 2,500 who respond every 2 weeks, and the other panel responds in the week in between. They're broadly representative by socioeconomic status, age group, and by region across the UK. And what we asked them to do is to record details of face-to-face conversational contacts that they had on the day before. And we do that because we feel that that is a risk behaviour. So, not just for COVID, but for any kind of close contact infectious disease. If you're having a face-to-face conversational contact with someone, then you could potentially spread the infection. So we asked them to record details of who they contacted in such a way, where that happened, how long that contact occurred for, how frequently they usually have contact with that person, whether it was inside, whether it was outside, whether we're wearing a mask, and so on. We also get characteristics of the person that they contacted. So the age of the person that they contacted in particular is an important characteristic. We started on the 24th of March, the first day of lockdown, of the first lockdown. We were desperate to get in before, but we couldn't quite make that. And over the first year of the survey, we had about 20,000 participants in total who recorded, with over 100,000 observations, who recorded the best part of 500,000 different contacts in the survey. And it's also part of a wider EU survey that's now being run in 20 different countries across the EU, which you can see on the map on the right. Different countries have dipped in, have done it, are doing it basically the same survey, but doing it at different points in time. So they haven't all done it from March until now. Although in the UK we have every week since March. And these are the sorts of results that you get from it. So this is just looking at mean contacts over time. And in the blue is adult contacts, mean rates of adult contact, and in the yellow it's the mean rate of contacts, including children and adults. And if you look, so you can see at the beginning, people were recording somewhere about 3 contacts per day, roughly, in the first lockdown. And that, to put that in context, in the surveys that we've done previously, before the pandemic, the average number of contacts people make was about 11. So there's a sort of 75% reduction in contacts made at the beginning of the first lockdown. And you can see that even after the lockdown eased, people really stayed cautious and didn't really increase their contacts very much at all until August, which, if you remember, coincided with Eat Out to Help Out, but other sort of encouragement for people, and the summer holidays, other encouragement for people to go about their business a bit more, and they certainly did, and contacts rose quite dramatically. Then the schools opened in September, and although there was restrictions, as you can see, on adult contacts in August, in the autumn, the overall levels of contact remained high because schools were open. And then there was a second lockdown, which reduced contacts a little bit, and Christmas, and then the third lockdown. And you can see Christmas actually is very effective at reducing contacts. And then the third lockdown, and you can see that gradually as the third lockdown has eased, contacts have started to increase. So that's the situation. We can look, of course, more and look at different characteristics as well. So we can look at some characteristics of risks. If I just take the left-hand graph first, and we take the two panels are for the different age groups. So the upper one is for younger adults, and the lower one is for older adults over the age of 60. And this left-hand panel is an answer to the question, coronavirus would be a serious illness for me. And you can see that in the red line there, those are individuals who, even though they're over 60 years of age, they suggest that they answered that they didn't think that coronavirus would be a serious illness for them. And you can see that they do make larger numbers of contacts than those who think that coronavirus might be a serious illness for them, which is the other coloured lines. And so there's some information. You can see that people's risk perception does seem to make an impact on the numbers of contacts that they make. And also not just the risk, but their risk perception, but their objective risk. So on the right-hand side is people who were categorised as being high risk. Do you remember that at the beginning of the epidemic, individuals were written to and told that they were high risk or not? And essentially that's what we're showing on the right-hand side. And again, it's for younger adults and for older adults. And again, if you just look at the older adults, those who were regarded as being high risk, that's the blue line, they do tend to make lower numbers of contacts than those who were not high risk. And they were slower to come out of, to increase their contacts in the summer and so on and so forth. So risk perception does make a difference, or makes some difference, but overwhelmingly the biggest driver of behaviour is the government interventions, as you can see from these different interventions. This is also just looking at different working patterns. So the top panel is looking for individuals in different part-time or full-time work and so on. And you can see that the people who are in part-time work, which is the blue, tend to make higher numbers of contacts than others in the community. And the bottom panel is looking at income levels, and they don't seem to be very well correlated with the overall numbers of contacts that people make. Finally, just a quick whiz, the last sort of one I want to show you just in terms of some of the results. This is mask wearing over time, and you can see mask wearing was very low at the beginning and has an increase very rapidly during the summer. And that dotted line that you might just be able to make out there is 24th of July when mask wearing became mandated in certain settings like shops. And so you can see that again, government intervention had a big impact on the uptake. You can see it very obviously. So I'll finish with just a few words about the strengths and weaknesses of the approach that we've taken. Well, on the left-hand side, I've got sort of strengths, which is, it means large, it's rapid, we do it every week and we get the results very rapidly, and broadly representative of the UK population. It does give us rapid insights into likely transmission dynamics and the effect of interventions. We can investigate the impact on different subgroups, as I tried to show you, so age groups or risk groups or both. And we can do that because we have, of course, information on that. And that's different to if you're looking at, say, Google mobility data, for instance. You don't really know who it is that's making those movements. And the other difference is that it's not mobility, it is actually contacts. So it's designed specifically to capture epidemiologically relevant contacts. So we're looking for people to record face-to-face conversational type contacts, and even you can even directly estimate the reproduction number from these sorts of contacts that we measure. And in fact, we were the quickest to sort of assess the impact of the first lockdown because we were using these data, which is much more rapid to come through than waiting for epidemiological changes that take some weeks. And finally, it's also a longitudinal survey, although I didn't emphasize that. And so we can follow people through time. And so, which gives us, a better sensitivity to pick up changes. In terms of the weaknesses, it's an online survey panel and a quota sample. And so, how representative is it truly of the UK population? Are we missing certain parts of the populace? Probably to some extent, yes. There's an issue potentially of people getting fatigued and getting bored of answering the same questions every other week. We haven't really picked up any evidence of that, but it is potential. And in fact, we don't allow people to fill out the questionnaire for more than 10 times, and then we replace them. There's an issue with collecting these sorts of data for children, so we have to get parents to do it, to complete it for children, and of course, how well they can really estimate or know the numbers of contacts and who their children were contacting is a moot point, but there's nothing else we can do at the moment, unfortunately. There's an issue about whether the definition of contacts is correct and whether it's been implemented correctly by the participants in the survey. So are they recording all of their contacts? In fact, probably more of an issue, are they recording too many of their contacts? So we get people occasionally, really most weeks, somebody reports hundreds of contacts, and they tend to be people who are working in certain sectors like retail sectors. And maybe they do make 500 contacts in a day, but it's likely that they probably don't, because it's likely that they're just not really following the definition as closely as possible. Are they really having a two-way conversation with each of those 500 people that they might record? And so to get around that, what we do is we tend to truncate. And so all the results I showed you is truncated at 50, actually. So people recording more than 50 contacts, that we just truncated at 50. And we do that because if you don't, this one or two people recording a few hundred contacts will drag the mean up quite significantly. So, but maybe they are reporting epidemiologically relevant information. So, I think we do need to investigate this and unpack this in more detail in the coming months. Validation studies of these sorts of things are seldom performed and difficult to do. So do they really reflect epidemiologically relevant contact patterns? We think they do, but we're not 100% sure. And then finally, although the sample is sort of broadly representative, you could argue that it would be better to boost certain groups, so perhaps certain ethnic groups, because we don't really have enough information to look to see whether certain ethnic groups, say for instance those of South Asian extraction, have higher rates of contact than the general population. It would be nice to do that, but it would require more effort, more money, and that's not going to happen right now. So just to finish up, this is some of the people working in the working group at the London School of Hygiene, and some of the people who've been funding these sorts of work. And I'll stop there. Thanks.
Thank you, John. We're just picking up on a couple of the questions which are about representativeness. I mean, you use the word broadly representative. I mean, that broad is an interesting question, because obviously what's really important is not to miss those groups that are actually most disadvantaged and we need to know most about. And a related question, which is how do you motivate or incentivize people to report every single contact, because it seems quite burdensome. And again, that speaks to the representativeness. And kind of associated with that is, what would these validation studies look like? Okay, so in terms of representativeness, I mean, we can measure it in terms of socioeconomic status, age, gender, and so on. In fact, we have quotas on that, and so we do. So the survey company, which is Ipsos Mori, do hit those quotas, as you might expect, and so it is reasonably representative for those sort of really broad categories, and we can check against the sort of census data, and it's reasonable. In terms of what was the saying? The third one was validation. The third one was validation. What we'd like to be able to do, and I think we've probably got enough data to do that, but is look at. We can look at self-reported illness, because we ask about illness. So we can look at self-reported illness. We don't know about whether it's confirmed PCR. We ask about whether people had a PCR positive test, and we can see whether those who record higher rates of contact are more likely to be positive. And so that's the sort of work that we can do. We haven't done it in any great detail. We've done it at the kind of broad brush level at the moment, but not in any great detail. Yeah. And what was the second question? It was about how do you motivate or incentivize people, because it seems quite burdensome to record. Yeah. So I mean, these are all people who are already on Ipsos Mori's panels, and so so they're recruited. So they're probably not exactly normal. It's not right. It's not the right word. Typical. Yeah, exactly. So they're people who fill out these sorts of surveys for Ipsos Mori. They get a very, very small sort of compensation for their time, but it's really very minor, and I'm always surprised that they do manage to do it. I actually don't think the survey is that difficult to do at the moment during the lockdown, because we don't actually make that many contacts, and so we're only getting sort of 4 or 5 contacts a day at the moment. So it's not a huge number of contacts. So I don't think it's that difficult for most people, but there are a few people who make a lot more contacts. Now, we do make it easier for people to list sort of group contacts if they've just made too many, particularly in a work setting. And whether we actually make it too easy, and so we end up by people just saying, oh yes, I made 100 contacts at work, and whether, did they really? I'm not sure. Okay, thanks. And maybe we can come back to the bigger question of, how does one show the representativeness of people who fill out surveys compared to the general population in the general discussion. But now I'd like to hand over to Professor Stephen Reicher, who's going to talk about, Stephen, will you say the... I'm going to talk. I don't have it in front of me.
Yeah, okay. So I should start by saying the others have used PowerPoint. I'm going to use a far higher technology, which is the human voice. I'm going to talk at you. My apologies for that. And I mean, one of the problems about these virtual sessions is I don't really know who my audience is, and I don't really know what your area is. I'm going to assume that many of you will not be behavioural scientists, might be life scientists, medics, and so on. So I want to start off with an analogy. If somebody was to ask any of you the question of what's better, a PCR test or a lateral flow test, you would tell me to go home and learn a little more and ask more sensible questions. Because you'd put it to me that actually you can't simply say what test is better. You have to ask what are the tests for. You have to ask whether you're interested in specificity or sensitivity, whether they're green light tests or red light tests, whether time is an important factor, that it's how you're using it rather than the test itself, which is critical. And so trying to establish an abstract hierarchy doesn't make sense. I think one of the problems is that when we come to behavioral data, we have a tendency to do that. And in particular, we have a tendency to say that self-report data is inferior, and if only we could, we would observe everything, and that would give us far better results and far more accurate results. And in a sense, what I'm going to argue very much, as the last two speakers have argued, is that there is no single royal road, no single method, that triangulate, bringing different methods together should be our mantra. I mean, first of all, when you look at the self-report data, it tends to be far more like observational data in some areas rather than other areas. So if you look at mask wearing, actually you see quite close concordance between observed data and self-reported data. When you look at social distancing, you find rather larger differences. Now that might actually tell you something rather interesting about social distancing and the ambiguities of what constitutes social distancing, and that people aren't being dishonest. It tells you something about the inadequacies of the information that is given. So the first point is that sometimes actually self-report is a rather good proxy for observational data. Sometimes it tells you something which observational data won't tell you. It tells you something different. It tells you something about what people conceptualize as what is normative, what is desirable, what is important. And that's critical if we want to understand, for instance, how people are likely to behave in different contexts, in private versus public contexts. So again, it's not that self-report is inferior, it tells you something different. Sometimes the really interesting thing is the relationship between the different data, between what people tell you and what they do, and why that's different in different areas, and what that tells you about the factors which are critical. So, as I say, for me, I don't think of these things as a hierarchy. I see them as different methods which can be used in different ways, and the real question is, how do we combine them? Now, the title of my talk was From Description to Explanation. And that's important because it answers the question, what am I trying to do? You know, I'm a social psychologist. I'm interested in the processes which govern behavior. I'm not interested in the levels of behavior so much as the levers which alter behavior. I, on the whole, don't find it that useful to ask, you know, what is the level of people's attitudes or people's behavior. It's how can I alter it? How can I change it? And in many ways during the pandemic, I think we would have done far better to ask, how can we change behavior? We've endlessly asked questions about, you know, will we be able to reopen on a particular date? A far more useful question would be, what can we get people to do which will lower rates of infection, which will make it easier to open up on whatever the date might be? So what are the levers? And of course, if you're asking about levers, you're beginning to talk about either looking at the relationship between variables in surveys or experimental studies in which you manipulate particular variables and so can look for causal relationships. And the interesting thing about both then is, well, certainly the latter, is that what you're doing is you're looking at the findings on a particular dependent variable, a particular metric under different conditions. Now, if the biases and distortions of any method of observation, right, are equal under those two conditions, they almost become irrelevant because they cancel each other out, and you can put down any change to whatever manipulation, whatever it is that you're actually manipulating. So again, there might be real problems in terms of just looking at self-report data in terms of telling us the level of a behavior. But if we look at change, either temporal change or change under different conditions, we can be more confident that we're getting at something real, that we are discovering a lever. What's more, when we use those experimental types of methods, and I'm talking about small scale, often laboratory experimentation, it opens the way to a whole world of creativity in terms of methods. So let me give you a couple of examples from the research that we've done. Now, in terms of distancing, one of the key processes that is likely to be involved is that of disgust. Disgust is the social ordering emotion. If we're disgusted at someone, we keep well away from them. And evolutionary explanations argue that disgust evolves precisely to keep us away from those who might give us pathogens. Now, as a social psychologist, I take less that distal explanation, the proximal explanation. I ask questions like, well, are we more likely to be disgusted by out-group members rather than in-group members? Will that alter the distance at which we stand from them? And so in my day job, I do things like get people to smell sweaty t-shirts, which have either got the logo of your own university on them or a logo of another university on them. And one thing we do, a self-report measure, is we ask, how disgusting is that? And what you find is that the out-group stimulus, the out-group sweatshirt, people, although it's exactly the same in terms of its smelliness, they see it as more disgusting. But
Steve,
we don't take that.
2 minutes.
We don't take that at face value. We then combine it with other measures. So we look at facial expression to look at levels of disgust. You can code facial expression for disgust. And we also look at how quickly people, after they smelt the t-shirt, rush over, wash their hands, how much soap they use, and so on. So we triangulate these different methods, and it's the relationship between these different methods that's critical. Now, to use another example more directly, over the last couple of weeks, we've been looking at people's distancing to in-group and out-group members. So we take England football fans and we look at the distance they stand from fellow England fans or Scotland fans. How do we do it? By using a simple virtual reality paradigm where they have to interact with someone, they go into a space, they can manipulate how far away they stand from that person. And indeed, we find that people are more likely to stand close to in-group rather than out-group members. We're going to do it in the England game in the next round as well to try and even out some of those things. But the point, again, that I want to make here is, in absolute terms, how far they stand away from the other is not at all realistic, deeply problematic, 10 times more flawed than any self-report measure. However, within an experimental paradigm, looking at the impact of the dependent variable upon the distancing, I think tells us something quite interesting about forms of distancing, which would then feed into the type of interventions we might want to make, say in mass gatherings, in terms of working on group norms around distance, in terms of working on people's sense of common group membership with others. So the bottom line and my final message is, let's not have a hierarchy of methods. Let's ask how we're going to use those methods together. Let's be creative in our methodology, and above all, let's triangulate.
Steve, thank you very much. And sorry for hurrying you along. I just wanted to other questions, discussion, but the points you make are very well made in terms of always thinking about what are we collecting data for, and also that any one type of data has always got limitations, and something like behavior, which is difficult to measure, absolutely triangulation is an important way to go. I just wanted to raise a couple of questions while others begin putting their questions into the into the chat box. Firstly, you mentioned you're not interested in level of behaviour. I mean, I'm a psychologist too, and I am interested in level of behaviour, partly because that established, do we have a problem or not? Is there something we want to change here? So I think I would say, we should be interested in levels of behaviour and those as baseline to then change. In terms of, I did like your lateral flow test and PCR reference, and I just wanted to bring in the issue about behaviour in relation to lateral flow tests, because the extent to which these are useful are crucially dependent on behaviour, which is how far do people put the swabs up their nose, down their throat, to have any chance of getting useful material. And we have this in a context where often people are very motivated, not, for example, to have children at home, when we know there is a false positive rate there. And so, there's both we actually need to know the micro behavior of how these tests are being done to have any confidence in them, but also we need to know the psychological motivational context within which the behavior is occurring. So Melissa, while I've been talking, have you been monitoring the questions coming in, and are there any you'd like to put to the speakers?
Yes, there are lots of questions coming through. So there's one for Stephen. What policy changes have happened as a result of analysing behavioural data, the sort of behavioural data that you were just talking about in this pandemic?
Well, there are two different answers to that. There's what forms of policy have been recommended by the various advisory groups and which ones have been responded to by government. And those two things aren't always the same. I mean, I would go back to Susan and her point about lateral flow tests. And of course, one of the key issues in whether you do lateral flow tests well or badly is the question of what are the consequences of finding yourself positive. And if the consequences of finding yourself positive are that you've got to self-isolate when you can't afford to do it and you can't do it practically, of course, there's a profound disincentive for doing it extremely well. So the importance of support for self-isolation is important not only in terms of self-isolation, it's in whether people get tested, how people get tested, whether you can use tests as a replacement for other things. Now, the government has made some moves around self-isolation. It has introduced the £500 support, which is available to 1 in 8 of the workforce, of whom approximately a third of those who apply actually get it, but it hasn't really addressed other forms of self-isolation. So I think various forms of research have pointed to the importance of self-isolation. There have been experimental studies, for instance, looking at intentions as a function of whether you give people scenarios where there are different levels of support, and we've done some of that work ourselves. There's been correlational work of the different groups which do and don't get tested. The Liverpool analysis of mass testing did that. So I think it's established a pretty strong case. I think there has been some reaction from government. I think there could be a whole lot more.
Thanks, Steve. Before we pick up any other questions from participants, and do please keep the questions coming, I want to invite Ed and John to have any reflections on the other two speakers that you've heard. So Ed, shall we start with you?
Yeah, no, I think I mean fully support what was said by Stephen there. I mean, multiple approaches is ideal, and I think it sort of and emphasizes a point which, so in often these cases we're not the self-reporting data is actually telling us things that we can't pick up in the data from the perspective that I'm seeing. But in the same way, when Stephen's talking about England and Scotland funds, I'm thinking of the ways in which we could scale that study out to not the local but the regional to the national scale, and through a variety of different data collection methods. So I think it's all about having these conversations that can actually start prompting those ideas. And so, yeah, that was my takeaway.
Thanks, Ed. Well, definitely this was one of the purposes of this session, was to bring very different kinds of behavioural data perspectives together with a view to the fact that if we can triangulate, if we can collaborate, so much the more powerful the data is likely to be. John, reflections from you?
Well, I couldn't agree more with Steve about triangulation. I think we've seen quite enough, and I think my data that we've shown, that I concentrated just on one survey, but of course we don't just look at one survey. We look at a whole range of different indicators, as do all the other modelers and epidemiologists trying to get a handle on what's going on and what might happen. The difficult thing is obviously, the stuff that we've been doing for the roadmap, for instance. The $64,000 question is, well, okay, we can measure perhaps what levels of contact we're at now using Comix or Google Mobility or whatever else, you know, use of credit cards and use of mobile phones and so on. But what will it be when the next step of the roadmap is taken? And that I can't answer. I don't know if anybody can answer or even give a reasonably good stab at it, because that really matters. You know, and just if I just put some quantitative numbers on it at the moment, you know, as I said at the beginning, before the pandemic, the average number of contacts that people made on a daily basis was about 11. These face-to-face conversational contacts was about 11. We're now at about sort of 4 or 5, so less than half of the numbers of contacts that are normal. So when we now in July, middle of July, 19th of July, and we take that last step of the roadmap, assuming that happens, will we go back to 11? If so, how quickly? That makes a really big difference. We're not all vaccinated yet. You know, if we step back and just go straight up to 11 contacts per day, go back to the sorts of behavior we had in February of 2020, that will make a huge difference to the epidemiology. But I don't think we will go back normal. But my guess, well, your guess is probably much better than mine, frankly.
Thanks, John. Very quickly, Steve, I want to get one other question which brings a different angle in before we've got 2 minutes left.
No, I mean, I think John's question is absolutely critical. I think it also raises a question, of course, about the relationship between theory and data, because one might have good theoretical predictions about the types of variables which might impact on how reopening has an impact. So, for instance, the impact of different types of communications and understandings on, on perceived risk and so on. So I think, good theory gives rise to good questions, which allows us to do some data collection about process, which may be relevant to that question of how can we make sure that those contacts don't go up. So, I mean, my answer is like you, I have no crystal ball, but I might have some sort of theoretical tools to tell me what some of the levers might be to make it less likely that it does go up.
Thanks, Steve. And just to bring a kind of biological dimension to this before we finish, there's a question here saying, following on from Adam's plenary, I don't know, John, if you're at Adam's plenary, well, actually, maybe this is for all of you. Can behavioural data interact with omics data? What questions could this answer and what would we need in place to do this? John, I suspect this was aimed at you as it came in during your speaking.
Okay, so can behavioural data interact with omics data? I'm not quite sure I fully understand that. But,
well, my interpretation of this is, how can we align behavioural data with biological data? Sadly, we're not going to have more time and we don't have more interaction in the audience to get people to explain more what they were asking about. But I think, again, it's about, if we can measure different genetic, physiological, etc., biomarkers, can that be then usefully brought into alignment?
I mean, I think one thing that I can think of is in terms of what the sort of sequencing data can tell you is clusters of cases, and you can look for where you've got clusters of cases occurring or links between cases, and they may align with, and you would expect them to be aligned with some sort of behavioural variables, because how else did transmission occur? If you can point to some cluster of cases, some transmission, then there must have been a behavior that actually underpinned that, because it is primarily a behavioral thing. That's how this disease is spread, is by our behaviors. And so yes, in principle, I think you could. I think in practice, probably a fair bit away from that.
Okay, I can see, I think Ed wanted to come in there, but Melissa has messaged me saying we need to finish now. So can I give a huge thanks, Ed, John and Steve, fascinating session. I wish we had another couple of hours, but I hope we'll find other occasions to talk to each other, to interact with the participants. And it was lovely to see so many people joining us to really develop thinking on this incredibly important, but relatively, I'd say, underdeveloped area. Needs much more investment. So thank you, everybody. And yeah, all the best for the rest of the conference.
Thanks. Bye.
Cheers.